So the patient has prior history of lung adenocarcinoma. So we have a few cluster of three-dimensional cells. The nuclei is enlarged. You see some like a variation in size and shapes and some nucleoli as well. The cytoplasm is really forming. So this is compatible with metastatic adenocarcinoma. So next specimen is instrumented urine specimen. It is from left ureter. So yesterday we see a couple instrumented urine, and we know that for instrumented urine it is common to have cellular fragment in tight like a cluster, because it is physically like a washout from the native urothelium. However, here the pattern is a bit unusual because you see hypercellularity, a lot of cells, and all of these cells have a little bit of mild atypia, which is you don't see like a normal NC ratio. The NC ratio is slightly increased, and you feel like the most of the cell looks the same. This is uniformity, or we call a monotonous appearance. This is somehow unusual, particularly for a reactive like type of urothelium. This pattern is unusual, and when we see here the cluster, we didn't see the umbrella cell at the periphery of the cellular fragment. However, in contrast to the high-grade urothelial carcinoma, we didn't see like a more remarked hyperchromasia, increased NC ratio, coarse chromatin. We didn't see any of these. So this is actually a typical presentation of a low-grade urothelial neoplasm. In the current PARI system, they emphasize to identify high-grade urothelial cells. So if you check the PARI's terminology, they would say negative for high-grade urothelial carcinoma, suspicious for high-grade urothelial carcinoma, positive for high-grade urothelial carcinoma. But it is very difficult to address the low-grade urothelial neoplasm because the diagnostic like a clue is variable. It's not very uniform. However, in two circumstances, we can highly suggest this is a low-grade urothelial neoplasm. This is the first one. If you see hypercellular but diffuse monotonous appearance or uniformity, and most of the cell have this low-grade type of atypia, like slightly enlarged, but you didn't see remark hyperchromasia, you didn't see remark coarse chromatin. This is suggestive of a low-grade urothelial neoplasm, which include low-grade urothelial carcinoma and PUNLUMP, papillary urothelial neoplasm of low malignant potential. The second circumstance is when you see like detached fragment of papillary architecture which was lined by the low-grade looking cells. At that time, you can also highly suggest that this is the specimen for low-grade urothelial neoplasm. So here we see some capillary meshwork lined by this monotonous looking urothelial cell. So this is suggestive of a low-grade urothelial neoplasm. But it was difficult to use the PARI system. Here we don't use the PARI system terminology. We still report the cases as negative, atypical, suspicious, or positive. So this one we will call it atypical, but we will make a note to address that the presence of monotonous urothelial cells and cannot exclude low-grade urothelial neoplasm. The patient actually had a prior history of low-grade papillary urothelial carcinoma as well as a papillary urothelial neoplasm of low malignant potential. So this is a typical presentation of a urothelial specimen that is suggestive of low-grade urothelial neoplasm. So this is a CSF specimen, which is quite unusual to see so many cells in a CSF. So it is definitely not normal. So most of the cells have these single cells, like arrangement, or like loosely attached to each other. And if we go on high power, majority of the cell have these plasmacytoid appearance, which looks like very much like a plasma cell, because you also see there's some pale perinuclear area, looking like this is the Golgi zone. And the chromatin pattern is actually, we would call it like soccer ball pattern, which is a chromatin pattern also quite often that you will see in a plasma cell. However, for plasma cell, we won't see something like this. So this is a cytoplasmic vacuole. In this vacuole, it looks like there are some like a orange or yellowish color stuff like inside this vacuole. It looks like a mucin, and it's not only one. It is throughout this specimen over here as well. And you see in here, and you see in here as well. So in the first glance, to me, I think, okay, this is a plasma cell myeloma. But when you go on high power, you start to see mucin. You realize, okay, this is probably a sigmoid cell carcinoma. So the patient indeed had the history of gastric cancer. And this is a metastatic sigmoid cell carcinoma from the stomach to the CSF specimen. Can we make a couple of these 那个 PT 留 PT 好了，这个是谁的？这是你的，对对对，帮我们做2张，捐给那个学会的 PT。Okay. The next specimen is also a pleural effusion. The patient has lung cancer history. So you see this is very common in our practice. We see probably 5 cases every day. So this is high-grade adenocarcinoma. The cell is markedly enlarged and abundant cytoplasm, quite foamy, vacuolated, and with 3-dimensional cluster. So this is positive for adenocarcinoma. Next specimen is also a pleural effusion, lung adeno. So you can see a lot of like 3-dimensional cluster. Even some you can see. Here is a psammoma body. So psammoma body can be present in primary lung adenocarcinoma. It's not very common, but you can definitely find it like from time to time. So this is a positive for adenocarcinoma. These are all confirmed, so we don't need to do a TTF1. The next specimen, we've seen a specimen from the same patient last week. This is a 68-year-old male. He had a prior history of lung cancer. And the last specimen we saw is a Pura effusion specimen, and this is ascites specimen. So the last specimen, we were initially suspect it's a recurrence of lung adenocarcinoma and with poorly differentiation. However, it turned out to be primary effusion lymphoma, which is positive for HHV8. And this is a specimen from different site. It's from ascites, but it is also a body fluid specimen. So here you can see this is hypercellular, and all these single cell has increased NC ratio with 1 to 2, like a smaller nucleolus, and this is typical for lymphoma. So this is the involvement of both pleural cavity and the abdominal cavity. And if we take a look of the Loustein, here we can appreciate the cytoplasm of the cells. Sometimes it has a very tiny fat vacuole. For higher grade lymphoma, it is common to see these fat droplets inside the cytoplasm. For example, like Burkitt lymphoma, some diffuse large B-cell lymphoma. Also, primary effusion lymphoma is within the spectrum of large B-cell lymphoma. And we also see the cytoplasmic basophilic rimming, like a basophilic granule inside the cytoplasm, which suggests it is a lymphoid origin. So this is compatible with large cell lymphoma. For the primary effusion lymphoma, the differentiation is B cell, but it is a terminal differentiation of B cell, so it won't express the common B cell markers such as CD20 or or PAX5. Instead, it will express the plasma cell markers such as CD138. And majority of the primary effusion lymphoma is also positive for CD30, and there is now an anti-CD30 antibody for the treatment, so it is applicable if the patient is intended to use this type of treatment. So because in this specimen we have more cells, we have nice cell block, so we will repeat the immunohistochemistry again in this specimen to save this for the teaching purpose. And yeah, so this can be saved for the teaching in the future because it is not very common to see primary effusion lymphoma. So the next specimen, this is from pleural effusion. The patient had a confirmed history of renal high-grade urothelial carcinoma, and it seems to be directly invaded into the pancreas adjacent organ. And now this is suspected to have pleura-like seeding as well. So in here, we can definitely appreciate features of high-grade urothelial carcinoma, which is hyperchromasia, enlarged nucleus, coarse chromatin, increased NC ratio, and so these cells definitely looks like high-grade urothelial carcinoma. So in this pleural effusion specimen, we call it positive non-small cell carcinoma. And given the patient's prior history of high-grade urothelial carcinoma, this is compatible with the metastatic urothelial carcinoma. So the morphology is different from the typical lung adenocarcinoma that we see, which has more abundant cytoplasm, more vesicular chromatin pattern instead of this hyperchromatic and the coarse chromatin pattern. So this is the pleural effusion specimen. So here we also see these like a poorly differentiated single cells, some with eccentric nucleus. Some looks a little bit like signaling cell because the cell has been pushed into the one side of the cytoplasm. the patient is not a gastric cancer patient. He actually had the history of pancreas adenocarcinoma. So in pancreas adenocarcinoma, rarely it can present as a poorly differentiated carcinoma with single cell. So this can be compatible with pancreas cancer. So again, this is from the ascites. Very similar morphology, but very prominent signaling cell feature. So this patient actually had gastric cancer. It's a different patient. So this is compatible with gastric adenocarcinoma with signaling cell. So this is much more typical for the signaling cell carcinoma coming from the stomach. The next specimen is from pleura effusion. The patient had a confirmed history of lung adenocarcinoma and has been treated. In this specimen, you can see the background is actually a little bit necrotic background, and with some like very atypical single cell with increased NC ratio. And some of the cells have more hyperchromatic nucleus, which is not very typical for adenocarcinoma. Some area you see this cell-in-cell pattern. So through the course of treatment of lung adenocarcinoma, the cancer can have several mechanisms to induce drug resistance. And through one of these mechanisms is called transdifferentiation. So some adenocarcinoma can transdifferentiate into either like squamous cell carcinoma or small cell carcinoma. This is also possible in lung adenocarcinoma. So in this specimen, we didn't see the typical adenocarcinoma feature that we see in the other specimen. Instead, we see much more like smaller cell, higher NC ratio, some with much more coarse chromatin, hyperchromasia. It is a little bit difficult to make judgment of the differentiation. So here we just call it carcinoma. I think there might be a little bit small cell transdifferentiation, but the biomorphology is very difficult because most of the time the small cell carcinoma has very high like a mitotic activity, some with prominent like choreoresis. So it is very difficult to tell if this is small cell or not. Some looks more like non-small cell, but because in the background they are like smaller cell, which also looks atypical. So it's very difficult to make judgment that if it's a small cell or non-small cell. So in this situation, we just call it carcinoma. I think this is positive, but maybe the tumor has already gone through some transdifferentiation, and so the treatment is not working anymore. Okay. Another pleura effusion. This is from a 65-year-old female. And this is a new patient. There's no prior history. So in this specimen, we find some large cell cluster. On low power, you can already appreciate it is very hyperchromatic. This is hyperchromatic. But the cell still has quite moderate amount of cytoplasm, and the arrangement of these cluster looks like a glandular differentiation. So it is a little bit atypical for lung adenocarcinoma that we just saw. The patient clinical finding suggests that she might have a peritoneal carcinomatosis, probably arising from GYN organ. So it is common if the abdominal cavity already be involved by adenocarcinoma of GYN organ. It is common to see concurrent involvement of the pleura cavity. So this is probably not primary lung. This is probably from GYN organ. It could be primary peritoneal or just like a tubal ovarian adenocarcinoma, most likely a high-grade serous carcinoma. So we would do a POX8 in addition to TTF1 to confirm that this is the very first specimen in our hospital. So we need to confirm the origin of the tumor. In the cell block, there's only very small cluster of cells. We will try if they are still there after reconstruction. We will check if it is positive for POX8 or TTF1. So let's move to fine needle aspiration. The first specimen is from the thyroid. This is a very paucicellular specimen. We didn't see a lot of cell. We didn't see a lot of background colloid as well. So there were only 2 to 3, like a cellular cluster. However, for the material that we receive, it is already diagnostic for papillary thyroid carcinoma. So here we see ground glass like a chromatin pattern, and most of the cells have a little bit irregularity of the nuclear membrane. Some show definitely nuclear grooving and overlapping. So this arrangement is very typical for papillary thyroid carcinoma. So this is the first cluster. This is the second cluster. In this second cluster, we also see pale chromatin and the oval shape of nucleus, irregular membrane, and here we see there's a pseudo inclusion over here. So even though we only have 2 cellular fragments, it is still diagnostic for papillary thyroid carcinoma. So we will call this case upfront to call it TBS6 PTC. So next we have 2 patients with pancreas cancer. This is pancreas EUS cytology. So for the EUS cytology, it is common to have some intestinal contamination. So this is from small bowel, small intestine, from the duodenum. You can appreciate the honeycombing arrangement, and they are scattered goblet cell in these nicely oriented fragment. Right next to these benign looking cells, these are very high grade tumor cell and with a tight cluster. So this is a pancreatic adenocarcinoma. You can definitely see what we call 1 to 4, which is a variation of the size of the nucleus in 4 times or larger. So this is 4 times larger than these cells, and this is definitely malignant. So the malignant cell can be intermixed with some benign cells, and sometimes it is not easy to pick them up. But in this case, because the tumor cell is very high grade, it is not the low grade tumor cell. So it is very easy because you can easily see the contrast to the normal cells and the tumor cell. So this is the pancreas adenocarcinoma. So another case of pancreas adenocarcinoma. So for this case, we didn't see a lot of benign looking cells in the background. Here we see a relatively uniform, not so polymorphic cellular fragment. However, we see very strange like orogenophilic mucin in these cell cluster. And this type of orogenophilic mucin is not normal in the pancreas. In pancreas, the mucin differentiation usually won't produce this orogenophilic color, and usually not into like a very scattered pattern. So because of the, we call these disorientation or drunken honeycombing, this is not well organized. Some nucleus are very close to each other, some very far from each other, and there are definitely some nuclear polymorphism over here, and a very strange like mucin differentiation over here. So this is adenocarcinoma. This is not normal. So these are all adenocarcinoma. We didn't see very prominent 4-1, but here you can definitely appreciate this is atypical, and this is 4-1 over here. So this is positive for adenocarcinoma. So the next case is a 71-year-old male. This is from a lung biopsy. This is from the touch imprint of the lung needle biopsy. So usually in this specimen, we don't have a lot of cells, and it can be easily like dry out to showing this drying artifact. In this specimen, there are definitely some cells with squamous differentiation, because you see these orogenophilic, very dense cytoplasm. So you see atypical cells, some with prominent squamous differentiation. So if it's a primary lung cancer, it is highly likely it is a squamous cell carcinoma, which is less common, much less common than adenocarcinoma. However, the patient has the clinical impression of a kidney tumor, kidney mass, which is really large, and this is suspected to have metastatic disease in the lung. So if it is a kidney mass with squamous differentiation, it is most likely it would be a high-grade urothelial carcinoma with squamous differentiation instead of a pure squamous cell carcinoma. So in this specimen, we call it non-small cell carcinoma and with squamous differentiation. And the clinician need to correlate with the primary site to see if it is coming from the kidney or it is a primary lung disease. So lastly, pap smear from a 74-year-old female. So the female had the clinical presentation of vagina spotting for 1 month. So she is 74, which means that is unlikely she still have menstruation. So it is a postmenopausal setting with postmenopausal bleeding. Although the pap smear is the tool for identify cervical cancer, cervical precancer, sometimes we can still detect endometrial lesion from the pap smear, usually from the bleeding and the debris from the endometrial cavity and the stuck inside the vagina. And sometimes the sampling can also sample the endometrial elements. So in this setting, usually the endometrial element would be markedly degenerated. So it is not easy to appreciate the morphology of the cell because it is already degenerated. And in the background, usually there are more like a necrotic debris as well as some inflammatory cell. So in this tight cluster, this is a cluster of degenerated cells with some polymorphism variation in nuclear size, and it is very tight, which suggests it's more like a glandular lesion instead of endometrial stroma, usually it's more dispersed and single cell. So it is likely a endometrial gland with a typical feature. Here we also see another degenerated cluster with more bubbling cytoplasm. Some of the cells have small but distinct nuclei. So this is also a cluster of atypical glandular cells. For this case, we call a typical glandular cell. It is likely from the endometrium, so it is endometrial origin. In here, we didn't, the cellular atypia, we cannot definitely call it is a malignant or it's just atypical. So we use the term atypical. And the patient already received curettage, and the curettage show a grade 2 endometrial adenocarcinoma. And in the cervical smear, we see a typical glandular cell and likely coming from the endometrium because of all the debris in the background. So it is compatible with shedding, abnormal shedding of the endometrium, and likely some of these glandular cells are coming from the adenocarcinoma. But with marked degeneration, we cannot have definite call. So this is the typical presentation of a postmenopausal woman with postmenopausal bleeding. And we identify some atypical glandular cell in the pap smear. So this is the case for today.
Thank you, Dr.
Thank you.